execution is easy. All top jaw surgeons can execute on a surgery, but what really separates the best from the rest is the planning, is determining what the movements are going to be. That's where the men are separated from the boys, so to speak. What does that process look like for you? What is sort of the ratio of planning to actual surgical time, et cetera? And how do you determine what is a beautiful jaw surgery, and how do you balance airway and beauty?
Yeah, so very great question. Very hard to answer. I will tell you, my appointments are very long. I'm very lucky that I have a practice that is not based on volume where I have to see 1 million patients a day. So my consultations are about 1 hour long. I take 100 measurements of the face. I really deeply analyze the CT scan. And that's just my initial consultation. After that, there's a lot of planning that goes into preoperative orthodontics, coordinating with their orthodontist to make sure that the teeth get to where they need to get to in order for me to do my surgery well and get the most out of it. Some cases are easier than others, right? Super retrusive. There's lots of room to move people forward without making them look weird or whatever. So some cases are not as complicated in terms of planning. Some cases are. I've had a lot of patients that were turned away by other surgeons who are like, they have sleep apnea. They're like, you have nowhere to go. I can't move you forward. You're going to look weird, like you said. I forgot what you called it, but
dogmaxxing.
They're like, you're gonna look bad. I don't want to be part of that case. And they came and saw me, and I was like, no, I think I can get you there. We're just gonna have to do some ortho in this way to maximize that. And there's obviously like lots of tricks we can do with how much we end up advancing the maxilla, but then maybe setting them up in an overjet before and then doing counterclockwise rotation. And there's ways of improving someone's airway enough to cure them without dogmaxxing them. I'm going to start using that word if that's okay, Ryan.
That's fine.
So every case is different, right? Some cases are just like, wow, I don't think I have the capability of bringing them as far as they need to come forward in one surgery. And that's a whole other thing. There's other surgeries that I do that we didn't talk about, but I do a lot of maxillary distraction too, in really severe cases, a lot of cleft patients that maybe have a lot of scar tissue and need big maxillary advancement, type of advancements you can't get from just doing an orthodontic surgery. You'll have to distract the maxilla forward first and then do corrective jaw surgery. So it's a really case-by-case basis. I would say that I've been lucky. I've been trained by some of the best people in the world. I've done a lot of them. I've got to work at the Breathe Institute where I've done so many airway cases now that I can usually achieve the airway results that I want without dogmaxxing people. So it's a really case-by-case. I think you have to be meticulous. If you treat this with the same attention that you give to a third molar case where it's like, okay, impacted, this is the risk, let's go. You'll get away with it most of the time, but I think a lot of the times you will get burned. I think if you spend the time in taking the right measurements and the right planning, I spend a lot of time planning these cases, and then using the tools and the technologies that we have nowadays with the planning to do the custom orthognathics and achieve those plans down to the 1/10 of a millimeter, down to the change of a 1/10 of a degree in orientation and stuff that we have now, with the utilization of facial implants and all that stuff. With the right planning, the right execution. I would say the execution's also important. You can plan, you can go in the OR, and you can use rubber bands to try to mask your occlusion not being great. I'm like I told you, I geek out on the occlusion during the surgery, my surgery doesn't end till their occlusion is perfectly stable and reproducible where I wanted it. So generally, my patients do not wear any elastics after the surgery. They're not rubber banded. They're not wired shut. They're not rubber banded closed. They have no rubber bands. They get to open and close because I nailed the occlusion. So it really is, I would say it's 50-50. The execution is very important, but the planning's super important. It takes, in many ways just as long, from the first consultation to the checkups and planning with ortho, and then coming in for their workup, and then planning after the workup, and then, then the OR time. All of that is part of it. And it takes a lot of, I think, concentration, attention to detail to get a good result.
Do you have any way of allowing a patient to preview what the soft tissue sort of real life final outcome of a surgery is going to look like? Yeah.
So, by the way, I studied that in my fellowship with Dr. Gateno, and most of those are snake oil.
Most of those softwares, you mean?
Yeah, they're snake oil.
Meaning they're not really accurate?
Mm-hmm. Yeah, we studied all of them. But basically, they exist. So I use them. So I have a 2-dimensional version where I could show you what your profile is going to look like, potentially before and after. There's a 3D version that I use as well. But in general, they're not very accurate. So to run an accurate simulation of the soft tissue before and after, it takes like a very powerful computer. I'm not going to say supercomputer, but a powerful computer, like 12 hours to run it. And it needs a lot of data to do it. So for example, you need to have a bunch of surgeries before and afters with different soft tissue thickness. With, it has to analyze how much fat and skin and muscle and stuff, and then what bony movements were done, and then what soft tissue changed to. And it needs to have a large database of that to be able to run an accurate simulation on what someone with similar skin, fat, muscle thickness with the similar movement would end up looking like. And they don't do that. It's much more like, okay, we're moving 5 millimeters. This is maybe how much the lip moves with a 5 millimeter maxillary movement. It's very bad at lips in general. It's very bad at predicting how the nose will change. So in general, I don't use it as a selling point to patients to say that this is what you will look like. I say you may look like this, you may not. The software is not 100% accurate. Again,
referring to the 3D MD hardware and software suite that has the multiple digital cameras, dynamic digital image of you.
Yeah, so the 3D photos will help you get a 3D soft tissue prediction versus a 2-dimensional soft tissue prediction, which I've used. But at the end of the day, it's giving you the same potentially flawed predictive outcome, but in a 3D format, which looks better. But it's not 100% accurate. It's not. The database is not there. Like I said, it really takes a big database of analysis of previous patients with soft tissues, analyzing their soft tissues with what bony movements they've had. And as far as I know, as of a couple of years ago, there's nothing that does that yet. So it's rough. I mean, sometimes it ends up being pretty close. I definitely analyze them before and after and see how close it was. And it's sometimes it's close, but sometimes it's not. It's just, I don't think it's designed to do that yet.